I'm afraid, yeah, I don't know. Okay, let's wait. Let's wait and see.
Okay, well, I think we can start. So thanks everyone for joining. We're very privileged to have Dr. Amina Chouch, who's one of our consultant neurologists here at the Manchester Centre for Clinical Neurosciences, who's kindly agreed to give us this talk on motor neuron disease. Am I right in thinking, Amina, that this is the same disease with Stephen Hawking had?
Correct. Yeah, yeah.
All right. Okay, fine. And so we have Sean Savale, our senior reg, co-hosting. So without much further ado, over to you, Amina. Thank you for coming.
Thanks very much for inviting me. When Joshi asked me to come and present for the neurosurgical teaching session, I wasn't really sure how to make motor neuron disease relevant, really. And then I thought, well, actually, let's use this opportunity to learn from each other, we neurologists and you colleagues, neurosurgical colleagues, and see how we actually overlap in many ways in terms of the sort of patients we see, but also in terms of the tools we use to make diagnoses and to hopefully make people feel better. So the title is somewhat, I suppose, intriguing. I look after patients with motor neuron disease, and the common subtype is called amyotrophic lateral sclerosis. As you have mentioned, Stephen Hawking is a famous gentleman, scientist, and a very brilliant man with fantastic books published by him, who had this disease for a long, long time. But most patients are not as lucky as Stephen Hawking's. And in fact, most patients will die within the first 2 or 3 years, which is extremely sad, I feel. In terms of the outline of this presentation, what I thought I'll do is go through some basic definitions and paradigms, and then move on to a diagnosis, epidemiology, etiology, natural history and prognosis, treatment, clinical trials, and a future perspective, focusing on what Manchester would like to achieve, hopefully, in the future. So in terms of definitions, so what is motor neuron disease? I suspect that most of you haven't seen many patients with this condition. This is a relatively rare condition, not because the incidence is not significant. I suspect you've all heard of multiple sclerosis and may have come across patients with this disease. And in fact, the incidence of motor neuron disease is exactly the same as MS. But sadly, most patients with motor neuron disease will be dead within the first 2 or 3 years. And that's why the prevalence is so low, and that's why it's very unusual for neurosurgeons to come across such patients. But typically the patient will present with relentless muscle weakness of the arms and legs. There is also significant wasting and muscle fasciculations. Typically the patient will describe weakness in one limb, which will then spread to the ipsilateral leg and then move contralaterally to involve the other side. Patient can have swallowing and speech problems, and they can develop respiratory failure. And in fact, most patients will die of respiratory failure and chest infections usually. In this particular subtype of motor neuron disease, patients will have a mixture of upper and lower motor neuron signs. They should not have any sensory symptoms or pain, and they may have some cognitive impairment. I just thought I'll show you some photos of what patients may present with. So the first photo is to show you the significant muscle wasting and weakness and the fasciculations of the tongue that we typically see in in ALS patients. You can also see in the picture next to it some evidence of muscle wasting of the small muscles of the hands, including the dorsal interosseous muscles bilaterally. And you may come across a similar finding clinically in your clinics in patients with cervical spondylosis, I suspect. The other typical feature is what we call a split hand. So again, you have a hand that's very wasted, and again, you can see the wasting of the first DIO. And if you ask the patient to turn the hand over, you can see some marked wasting of the thenar eminence, which is typically seen in motor neuron disease, and that seems to distinguish it from the C8 radiculopathy, which you probably see a lot of in your clinics. So how can I make motor neuron disease or ALS relevant to my neurosurgical colleagues? I thought I'll I'll mention this paper. So this is quite an old paper now, which did a retrospective study looking at more than 1,100 patients with ALS to see whether or not these patients received any surgical treatments. And sadly, these patients some of these patients did receive surgical treatment because their symptoms mimicked what would a neurosurgical colleague identify as a cervical radiculomyelopathy or a lumbar radiculomyelopathy. So just to bear in mind as a surgeon that you may come across these patients in the early stages of the disease, and you will have to be very wary of not missing any red flags to distinguish ALS from what is straightforward spondylosis. So I just decided to, I don't know whether you can see that actually. So I can't move these windows, I'm afraid. They just keep popping on my screen. But essentially, if I just reiterate what I've just said, so out of a cohort of 1,131 patients with ALS, 4.2% underwent decompressive spinal surgery after the onset of the disease. Remember, these patients didn't have a diagnosis of the time. They just presented with wasting and weakness of an arm or a leg or a foot drop, and had some spondylitic changes on the scans and were initially treated as surgical cases, but then later on developed progressive weakness, which is what we typically see in ALS, and then respiratory failure, swallowing difficulties, and sadly, demise. What I would say about this issue of ALS mimicking spinal, I suppose, cases is to remember that somebody who has no pain, no sensory symptoms, just a foot drop, I think, and perhaps a slightly brisk reflex on the same limb, just be wary that this could be something else and not a straightforward, L4-5 radiculopathy. So keep an open mind, make sure you examine the patient fully, make sure you examine your cranial nerve. Sorry, I'm a neurologist, I'm about to say that. Check the tongue, ask about swallowing and cough, check the upper limbs and the legs, make sure that you have checked the reflexes properly and the planters. And if there is no sensory involvement, there is no pain, just keep an open mind. And if there is progressive decline over time, which may be too fast for a lumbar radiculopathy, try and think laterally. And perhaps what you need to do then is to get some nerve conduction studies and EMGs that may pick up some changes and guide you in terms of making the correct diagnosis and not over-treating patients as described in this paper. So I think that's all I have to say, but I think it is relevant in a way for my surgical colleagues to be aware of this condition from a very practical point of view. So if I go back now to the condition itself, we have known about this condition for more than a century. And despite that, we haven't been able to find a cure. And despite that, like I said, more than 50% of the patients would be dead within 3 years. And in neurology, Jean-Martin Charcot is the father of neurology generally, and did a lot of work in La Salpêtrière in Paris a long time ago, describing this clinical entity in great details. And he was fantastic in terms of describing the clinical phenotypes, so the examination findings, the tempo, the course of the illness, but also in terms of correlating the clinical side with the histopathology, which is clearly very important. And when I first saw this in one of the reviews, I was rather puzzled that such an important figure of neurology would be so confident about in terms of saying the diagnosis as well as the anatomy and physiology of this condition was very well understood, and that in a way there was nothing else to clarify. But I'm not sure he meant that. And perhaps what he meant was we are very good in making the diagnosis despite the paucity of clinical investigations available to actually confirm the diagnosis. We neurologists often pick up the diagnosis in clinic just by taking the story and examining the patients. And in about 90% of the time, we are sadly quite confident to say we may not be able to help that individual, sadly. I thought I'd show you some nice pictures because I love history and I love illustrations, and I was quite amazed that more than a century ago, physicians and pathologists were able to do postmortem studies and beautifully draw these figures to tell us that the primary problem or the primary hallmark of this condition is degeneration of the motor neurons, which you typically find in your anterior horn. So a lot of work was done in terms of post-mortem studies, looking at spinal cords, looking at brain histopathology, and provided great insight as to where the problem is, which is really important. Another beautiful figure published, again, more than a century ago, just showing you the degree of degeneration seen in the anterior horn and highlighting that this is quite a localized process that seems to spread along particular tracts within the motor system. And that's why what we see in clinical practice is a pure motor syndrome. So I don't expect patients with ALS to have any sensory disturbance. I expect them to have progressive weakness and wasting with fasciculations and brisk reflexes because of where the pathology lies. So like I said, for more than a century, we didn't really understand what this condition is. We knew what the pathology showed us, but we didn't understand what the process was until recently, actually, fairly recently. So 2011 doesn't feel like a long time ago, but it is 9 years ago. And some gene mutations were identified in some familial cases of ALS. And we realized that the same gene could present with this pure motor syndrome, but could also cause, I suppose, fairly common forms of dementia called frontotemporal dementia. This is a form of dementia usually occurring in the younger population and typically associated with behavior and personality change. So the memory is spared, which normally you see in patients with Alzheimer's disease, but the behavior can be disinhibited, can be inappropriate, patient can start swearing, they start doing things that you would not expect them to do, and that can be very traumatic for the relatives and the close family. But what these genes managed to highlight is actually ALS is part perhaps of a spectrum of disease, and ALS has now become a neurodegenerative disorder that seems to extend along this spectrum, starting with a pure motor syndrome and perhaps evolving into a pure dementia syndrome. But remember that some patients will have an overlap of the two conditions. I'll go back to histopathology because I think brain tissue and spinal cord tissue will always remain very important, and I'm sure you agree as neurosurgeons of that. It is very important to take a piece of tissue and look at it under the microscope to see what's going on. Is still the most practical and real way of ascertaining what's going on. And where people looked at brain post-mortem tissue in ALS patients that identified these little inclusions that contained a protein called TDP43. And what's interesting about TDP43 is that normally this protein lies in the nucleus, and somehow, because of whatever is happening in these patients, the protein is misplaced and seems to shift from the nucleus into the cytoplasms and create these inclusion bodies that are fairly consistently found in most ALS patients. So perhaps that's telling us there is a common pathway that leads to this terminal and stage degenerative process. How does this happen is very difficult to explain, but clearly there is something there that we need to focus on. And in a way, it's a very useful biomarker in terms of confirming the diagnosis post-mortem. As I mentioned earlier, so we neurologists do see these patients infrequently, which is probably a good thing, and we rely on the clinical acumen of the clinician to make the diagnosis, and we rely on investigations to make sure we're not missing something treatable, really. So we're not using any tools to confirm the diagnosis. What we do is scan the patients. Often patients with ALS will have an MR brain and MR cervical spine to make sure we're not missing a treatable cause, like a neurosurgical problem, whether it's a disc or whether it's something else that could account for the patient's muscle weakness and wasting. I've mentioned two diagnostic tools here. The first one was agreed upon in a big meeting in Spain called the Als-Corial criteria, published in 1994. So these criteria were literally created to allow patients with ALS to join clinical trials. And they are there to describe a combination of clinical symptoms and EMG findings that would allow patients to hopefully be recruited in different studies. The Japanese later on in 2007 added more criteria just to, in a way, tidy up what was created in 1994 and to allow for more patients to be recruited. Because remember, with de-innovation, you and I may be able to pick it up clinically by seeing evidence of muscle wasting and fasciculations, but an EMG study will probably pick up more than we can see with the naked eye. So it's important to do studies that, in a way, clarify the extent of the disease. And often with ALS, you will identify more changes on the EMG that you can't see clinically. And that's why I think, as a neurosurgeon, I would say, if somebody comes to you with a painless foot drop that's progressing, and they may have a brisk knee jerk ipsilaterally, just be careful that this is not ALS and make sure that you examine the patient fully. And if you're not comfortable with what's happening, get an EMG. So the scan may show you some, spondylitic changes that you may think are enough to explain what's going on, especially if there is root compromise at the L4-5 level. But if there is something unusual, back up your impression by getting some nerve conduction studies and reassessing the patient before proceeding with decompressive surgery. The problem with these criteria is they don't pick up all the patients, and they also don't look into the cognitive side of things. So what we have realized in the recent past is that a great number of ALS patients will have cognitive impairment and may even develop frontotemporal dementia, which I mentioned earlier in one of the slides. So useful in terms of allowing patients to join studies and to hopefully stratify them in some sort of logical order, but insufficient at the moment. So the next slide is looking at the epidemiology of ALS. So in terms of how we study epidemiology in very rare conditions, for a long time, it was very difficult to actually do this properly, and people had small case series describing what they saw locally. But the advent of registries has allowed us to make things much more fluid, I suppose, and to allow patients to join by their own volition. So patients now can self-report and can join in different patient registries across the world and be part of these longitudinal natural history studies. So now you can capture more patients by using patient registries. The patient can register themselves, or the clinician can do that for them, and together we can follow up these patients in a more systematic, consistent, I suppose, rational way, which hopefully will qualify the true pattern of the disease and how these patients evolve over time. So if I go back to the data available about ALS, most of the data is derived from the European patient registries, and we haven't got much data yet about cases in Africa and Asia, but I'm sure that will change fairly promptly with the advent of the new technologies and all the I suppose the internet and things like that. So I am fairly optimistic that the world will become even smaller in the next 5 to 10 years to allow us to share and look at things in a much more holistic way, actually, and global way. But essentially the incidence is about 2 patients in 100,000. Male individuals seem to be slightly more affected than female individuals. There seemed to be a north-south gradient, at least in Europe. So patients from Northern Europe in Scandinavian countries seem to be more affected than Southern Europe, for example. We also know that there is some east-west disparity. So cases that reported in the West seems to be greater than cases reported in India or Asia, for instance. But I always worry about the lack of reporting in those parts of the world, but I'm sure that will change fairly soon. There is also some suggestion that certain homogeneous populations, as in genetically homogeneous populations, as seen in Ireland, for example, or certain white communities in the US, seems to be more prone to develop the disease. So the more inbreeding there is, the higher the genetic risk, it seems, of developing this condition. So in terms of risks associated with ALS, it seems that age is probably the most important denominator. So the older you are, the higher risk of developing ALS. Again, male gender seems to predispose individuals to some degree, not significantly, but to some level to this condition. Smoking, education, and high cholesterol have recently been reported as potential risk factors. Now, people will always talk about toxin in ALS because perhaps now 30, 40 years ago, there were some clusters in Japan, in the Guam Islands, where individuals who ate certain seeds, cicasin seeds, and also in India, where individuals were using certain seeds to make some types of flowers, developed a particular type of ALS. So they had a significant weakness, wasting, but they also had dementia. They also had Parkinsonism. So they had a complex clinical picture, and they seemed to die fairly soon. And what it was felt at the time is perhaps the environment was the trigger, and a change in the lifestyle seems to have made this cluster disappear, actually. So if you look at the recent figure in terms of incidents in Japan, in those particular islands, they seem to have normalized. So whatever has happened a good 30, 40 years ago seems to have normalized. In terms of other potential risk factors, people have talked about pesticides, heavy metal solvents, but again, the evidence remains fairly limited. But perhaps like I said, the advent of big registries across the globe where people share data and follow patients for long periods of time will allow us to clarify whether or not there is something there within the environment that creates this predisposition to ALS. So in terms of the cause, I talked about risk factors, we talked about epidemiology, then we talk about etiology. So the reality is that we don't know what causes ALS. And that's why we can't identify a treatment that can stop people from dying after 3 years. But what is currently believed in terms of basic science research is that perhaps a genetic predisposition with a particular environment and lifestyle will lead to patient developing this condition. But again, this remains a hypothesis that needs to be confirmed. But a lot of work is being done to clarify some of these issues. So in terms of genetic in ALS, people have always felt that identifying genes is the key to solving problems, but with ALS, it has always been slightly more complicated than that. So I think the first thing I'll have to say is that genetics actually accounts for only 10% of the cases. So if you look at the first figure, you can see that 90% of ALS cases will be sporadic, only 10% will be familial and will have particular genes. The commonest gene defect we see in ALS in the West is the C9orf72 gene, which accounts for about 50% of the familial cases and about 10% of the sporadic cases. So even if you're a sporadic case, there's a very small chance that you may have a faulty gene. So the second graph is there to tell you that since 1993, which is when the first ALS gene was identified, more than 40 genes have been discovered. Some of these are disease-causing mutations, some of these are association genes, which seem to predispose patients to have the disease. But despite all these amazing discoveries, really, using next-generation sequencing, especially since 2010, when the tool was discovered, we haven't been able to clarify how we could modulate the disease and improve outcome. But this is certainly a very important work that we have to focus on, because it gives you a very concrete biological marker to focus on. So by having a pathogenic mutation that you can replicate in an animal model, you can then move on to understanding the pathology and hopefully go back to the patient to try different treatments that could hopefully make them better. So there is very clear reasoning in terms of the importance of gene discovery here. So in terms of the pathophysiology. Sorry, I've got this box in front of me, which is very frustrating, but I'll try to ignore it. So like I said, despite the wonderful and amazing discoveries we've had in the last few years, the pathophysiology of ALS remains, I would say, poorly understood, and people have worked really hard using different animal models where mutations from known pathogenic genes allow you to see what's going on at a cellular level. And what we have realized that different pathways seem to be impaired, seems to be disturbed by during I suppose a disease like ALS, and you can see that the pathways involved are ranging from impaired protein homeostasis, oxidative stress, mitochondrial dysfunction, RNA metabolism abnormalities, and all of these seems to culminate in nerve degeneration and weakness. I thought I'll mention this particular disturbance that has recently been identified in ALS patients, and that's immune dysregulation. So what we have known for a long time, that if you look at post-mortem brain tissue in ALS patients, you will identify a lot of neuronal cell loss as I mentioned earlier, and you'll identify the TDP43 inclusions. The other thing you'll pick up is immune cell infiltration. So T cells seems to accumulate around the dead neurons, and nobody seemed to understand why. And more recently, what has been discovered is that actually, if you take a peripheral blood sample and you start immunophenotyping the cells, you realize that the cells are also abnormal. And in particular, the T regulator cells seems to drop in number over the course of the disease. So whatever is driving this seems to trigger a disimmune problem within the brain tissue itself, but also in the periphery. And why I mentioned this? I mentioned this because we know so much about immune modulation. We have so many agents, from all the cancer work done, from all the rheumatology work done, where specific particular agents can be targeting particular pathways within the immune system and hopefully improve outcome. So that's something we're very keen to develop in Manchester. And in fact, my colleague, John Ealing, is currently the PI for this interleukin-2 trial, which is there to enhance the function of the T regulator cells, which I mentioned seem to decrease over the course of the disease in patients with ALS. So some promising work there. I think we should keep searching, keep understanding how immunomodulation could influence the disease, but it's certainly early days, I think. I'll move to a slightly different, I suppose, aspect, and that's prognostic factors. So we talked about risk factors, we talked about etiology, we talked about immunomodulation. Now we talk about what makes you think when you're in clinic that this patient will do less well than somebody else. So the older is the patient, the less likely they are to do well. The quicker is the disease progression at the beginning of the presentation, the quicker they are likely to die, sadly. If they have swallowing problems, they seem to progress fairly quickly and tend to develop chest infections quite early on, and again, deteriorate soon after. If they have cognitive impairment and even frontotemporal dementia, that seems to trigger problems sooner rather than later. And then genotyping. So patients with the commonest form of ALS, the C9orf72 mutation, seems to predispose patients to a poorer prognosis. I thought I'll mention this study. I'm not sure whether you can see the title. So this is the type of work that people are doing now by collecting a lot of data. So by having data from thousands of patients across Europe, which is what has happened now thanks to the patient registries, you can use different algorithms that allows you to combine different clinical parameters and see what factors in a way can cause or can be associated with a poorer prognosis. And a Dutch group published this paper 2 years ago now using a particular algorithm, and they seem to show that you have certain features. So if you're older, you have breathing difficulties, you have swallowing problems, and you have the C9orf72 mutations, you are likely to do worse. And they can even predict what sort of survival and life expectancy you may have. Yes, they could potentially be useful in the research setting, I suppose, when we are at the onset of a study and we want to plan things in terms of, how long do we need to monitor the patients, what sort of biomarkers we should be checking. But I always worry that these tools may be misused. So you can imagine if I'm in clinic and a patient comes to me and says, "Doctor, how long I have to live?" The last thing I want to do is to tell them they've got 12 months and 4 days, because that would not be very kind. I think what we have realized in clinic, that it's very important to maintain hope, and it's very important to emphasize that every individual is unique and that the journey is very uncertain, especially in the beginning when we meet them. And it's very important to boost the morale of the patient, because if they give up, they will die more quickly. That's something we all know as clinicians, actually. I thought I'll mention this paper because you are probably more familiar with this tool than we are in neurology. So a lot of work has been done in terms of brain imaging, or I suppose imaging of the neural axis in neurodegenerative conditions ranging from ALS to Parkinson's disease to Alzheimer's. And we have known that you can see cortical spinal tract degeneration in a straightforward MR, but that particular pattern didn't seem to correlate with the disease. So I suspect by the time we see the change on the MR, it's too late, and the change itself is not sensitive enough to allow you to monitor the disease progression or any response to potential treatment. But then what's wonderful is that the technology is improving every day, and now there are certain tools, certain modalities within the MR tool itself that allows you to see things better, to look at the white matter tracts better, and to see what's happening almost at a cellular level. I think at some stage we'll be able to see so much just by using the right technology, and that will certainly be a much better a non-invasive way of assessing disease progression and any potential response to treatment. So here, this Nature paper was published, I think, fairly recently in 2020, actually this year, showing the usefulness of diffusion tensor imaging as a biomarker for ALS. So they took 94 patients, I think, and monitored them over a period of time and showed a clear change in terms of the pattern of disease progression in these patients. So you can see here there is a clear overlap between what you use in your clinical practice and what we could be using initially in the research setting, but hopefully later in a clinical setting as well. And that's why it's very important that we keep in touch, that we work together, that we learn from you. But certainly I think my neurosurgical colleagues have access to some fantastic tools that we neurologists should be aware of and should be thinking about extrapolating and using in our practice. So I think I kept emphasizing how sad and tragic the, I suppose, the disease course is with ALS, but I must highlight that there is one treatment available in the UK called Riluzole, and it is actually the only licensed treatment we have. And it was developed by a French group more than, 20, 30 years ago now. But sadly, it can only improve survival by 2 or 3 months. And in fact, a number of our patients decline to take it because you need some blood monitoring with it. So at the moment, we don't have anything that's effective and useful, I suppose, in terms of improving life expectancy significantly. This is another paper published by the London group, I think 2 years ago now, looking at how this treatment that I've just mentioned to you could be influencing disease progression. And again, I'm trying to highlight here the importance of collecting data. So if you start having big clinical databases, which hopefully we can, as a self-trust, achieve at some stage, you can do big retrospective studies. So in this particular work, they looked at 900 patients, and they tried to see at what particular stage of the disease does the Riluzole improve survival. And they seem to say that it is usually in the later part of the illness, when the patient is relatively quite disabled, is when you see a clear benefit from taking this drug. And some of my patients now have become aware of this paper and actually tell me, well, what's the point in, extending my suffering later in my disease if there is nothing that's going to make a huge difference? I'd rather not take anything. So patients are very clued up as to what's going on in the ALS world, actually. This is another paper just to tell you that a lot of work is being done in terms of trying to find a treatment, but also I think the concern I have, a bit like what happened recently with the pandemic, sometimes people rush into publishing things without gathering enough data that can give you clear answers and allow you to make good practical decisions. So this was a Japanese paper published, I think 2 or 3 years ago now. And they took a very old molecule that was worked on a good 20, 30 years ago and tested it on Japanese patients. The difficulty I have with this paper is that the treatment itself has to be given intravenously every 2 weeks. And they followed up patient for 6 months, and they seemed to show that there was a slight improvement in a particular functional scale by 2 or 3 points. But how can I translate that as a clinician from a research paper looking at patients over 6 months to something I can use in clinic and justify using within the NHS, framework, without overspending, without harming the patient, and without being over optimistic? I think we have to be optimistic, but I think we have to be honest and fair. And with that particular paper, I think most of the scientific community in the UK and Europe has felt quite uncomfortable that the study itself has not been carried out for long enough and didn't provide any data in terms of survival. But also the logistics, how can you justify giving an intravenous infusion every 2 weeks and not show me that it's going to make a true difference to the patient? So in the UK at the moment, we're not using this treatment. They are using it in Japan. You can have it on a private prescription, but we certainly here are not using it. I think the FDA actually has licensed this treatment, but again, there has been some reticence, I think, from the community generally to use it. So it's early days, I think, for this particular treatment. So the one thing we do in clinic in a very systematic way, I suppose, is to focus on symptom management in patients. And we are very reliant on an MDT approach to achieve that. So I'm part of a large team of consultants, nurse specialists, therapists, psychologists, psychiatrists, palliative care consultants, and we all endeavour to hopefully make patients better. And sadly, these patients will progressively become weaker and weaker. They can become emotionally labile. They can become depressed. They can have pain, spasticity, nutritional problems, and respiratory problems. And all of these issues have to be addressed within the MDT team. In terms of clinical trials in ALS, because we don't understand what the biology is, very few agents have been able to show any benefit when you try them in clinical trials. And we in Manchester have been involved in clinical trials for a long, long time. In fact, John Ealing and Hisham Hamdallah have been leading this for a good, 15 years now, I think 14, 15 years. And people often talk about failure of, trials in providing answers to ALS patients. But I think you have to remember that hope is very important. And although I've always been very strict in terms of excluding, biological agents with rather woolly evidence, what I've come to realize with ALS patients is that if there is reasonable evidence or reasonable rationale in using an agent based on, animal work or bench work, it may be worthwhile trying this in trials in a very safe, of course, way. So you need to make sure the agent is safe. You make sure that there is reasonable scientific evidence that in a way pushes you to move forward with a clinical trial. But I think maintaining home is really, really important here. So I think I've been talking a lot about what ALS is and how little we know, I suppose, but I think, like I said just now, it's very important to maintain hope. And when things feel very much out of control, it's very important to go back to what we really do in clinical practice, which is to look after patients. And in Manchester, we look after a fairly large cohort of patients, so 224 active patients. Remember that a lot of the patients will be dying at the same time, sadly. A great proportion of these patients are male, some of them are female. These lovely figures are derived from the dashboard that my colleague David Rogg has been working on at Salford. So we're very keen on starting to collect clinical data so we are able to join all these big collaborative projects worldwide. And it's very important that we do that together so that every department is involved, so we can learn from each other and share as much as we can. This is another I suppose, aspect of what we want to do is to again, epidemiology is very important. It's very important to know where these patients live. It's very important to know, what sort of conurbation we are covering as a service. And you can see that patients come from all across the Northwest, and some of them come all the way from Crewe to see us. And the numbers seems to expand actually all the time. So, and that's difficult to understand. Is it because patients are aware that there is a specialist centre where they can be looked after in some sort of holistic way? Or is it that the numbers are increasing? We did say that age is a significant risk factor, and we do have an aging population. So perhaps that explains some of the recent rise we had. Again, I was looking at this table, and this is telling us how many referrals we get in Manchester. The range is rather wide, from no patients in 1 month to 13 patients the other month. But what you can see in the in one of the columns is that every month a number of patients will die. So I'm part of a large team. So this photo does not include everybody. So John Ealing and Hisham Hamdallah have been the leading consultants for a number of years now. We have some very senior nurses who are very passionate about the work we do, and we have plenty of therapists who show great compassion towards these patients. And the team doesn't lie just in the Salford Hospital. We have colleagues working across Greater Manchester in the community, but also in other hospitals, including the ventilation service, who try their best to ease the suffering of these patients. So the future, I started off my talk by reporting what Charcot had mentioned about the disease itself, how he was able to define it more than 100 years ago. And I go back to Charcot because I think Charcot has been very passionate about his work, but also very compassionate about the patients. So where shall we go next? I think I'll just repeat what Charcot said, which was to keep looking, keep searching, and to never give up. And hopefully one day we'll be able to change the verdict we tell patients, and hopefully we'll be able to tell them that there is a treatment that will make them feel better and help them live longer. And that's certainly something we in Manchester are very keen to look forward to. I'll move on now to some of the things we are hoping to expand in terms of research in Manchester. So the Salford Trust is very keen to create more of a translational platform that would allow the integration of the wonderful clinic work the team does and incorporate more research into it, because I think that's really important long term in terms of maintaining hope more than anything. So collaboration is key. So everybody is very frightened when they work by themselves, but as soon as you pull people together, it just feels more comfortable and more positive and more achievable, I suppose. And one of the projects I was keen to collaborate on was a soft robotic project with the Salford University, because I came across a number of ALS patients who had significant upper limb weakness. So they didn't have any cognitive impairment. They were still working, believe it or not, but their arms were becoming increasingly weak. And I wasn't sure whether there was something that we could do from a technology point of view that could improve things. And I was quite surprised when just before the pandemic started, when the government announced almost like a full scheme, a national scheme focusing on robotics and artificial intelligence to improve health and social care. So hopefully there'll be more, I suppose, support to achieve that. And what we have done in Manchester is to have a patient focus group, and I was amazed at how excited the patients were when they were able to wear some of the devices and see their arms move. It was quite impressive, and it was just very touching to see the wives actually cry when they could do that. So clearly every little change, every little thing we can improve will make a huge difference to them. The other thing we are very keen on in Salford is to develop I suppose, a more robust clinical trial platforms. So you may be aware that gene therapy is very much on the horizon, and that treatment, those particular treatments may become part and parcel of what we do in clinical practice. And I mentioned the C9orf gene, which is the commonest cause of familial ALS, and there is currently an ongoing phase 1 trial in Sheffield and London. The results are still pending to see whether or not this treatment is actually safe. So we can start looking at a phase 2 and hopefully a phase 3 if it does work. And Salford has managed to be a backup site for that. So I think that's really good. But again, organizing this was very much a matter of pulling people together from hematology who are familiar with intrathecal chemotherapy, ITU, the MRI CRF, everybody who had some experience and some understanding of the problem to try and make this happen in Salford. The other thing Salford is very keen on is biobanking. I've mentioned to you earlier that brain tissue, spinal cord tissue, blood samples are really important if you want to do good research. So you need very good clinical phenotyping, you need very good databases, and you need human biomaterials. And the only way to do that is to be able to access or donate, ask the patient to see if they are willing to donate samples in clinics. So in Salford, we've started collecting samples from the clinic over the last month, and I'm hoping that we'll be able to have a reasonable collection that we could collaborate with different scientists in the UK, but why not worldwide? The one thing to say is funding is really important for biobanking. And unless we collaborate and apply for grants together, it will be difficult to maintain this. So it's really important that we work together to achieve that. And I'm hoping that, you know, with the support of the Salford Trust and the different organizations, we'll be able to maintain this. And remember that this is a long-term investment for the sake of the patients. So that's my last slide, really. So I think the whole point of what we do, and I'm sure you agree with that, is to ease suffering and make patients feel better while remaining very vigilant and very rational and very hopeful in terms of what we do. And that's why we do what we do. And I hope you found this useful. It's slightly different from your normal talks, but I hope I have made it to some degree interesting for you. Thank you. Hello?
Hello, thank you, Dr. Chouch. That was great. Can you hear me?
Yes, I can.
Yep, thanks a lot for the talk. Very relevant to our practice as well, in terms of not forgetting it as a differential if things don't fit clinically. Mr. George has raised his hand. I think he's got something to add.
Yes, thank you, Emina. That was quite interesting, actually. Horrible disease, and thank you for putting so much effort into it. You may have touched upon it already, and so forgive me, I couldn't watch the whole talk completely. I'm just doing a list at the same time. The role of ventilation. Once patient needs ventilation, what's their prognosis?
Well, not great. So it's a good point, actually. The ventilation, so the earlier you develop respiratory failure, the less likely you are to do well. Ventilation is supposed to improve survival by up to 12 to 18 months. So the patients will usually tolerate it quite well overnight, but then they'll become dependent on the ventilator. We'll start using it during the day, and that's when the problems start. So life expectancy is usually a year to 18 months after that. That's what we normally see.
I see. So how did Stephen Hawking manage to survive so long?
Because he's got an unusual form. Yeah, so so he's very much at the end of the spectrum, to be honest with you. So I think, he's quite exceptional in terms of what he's had. And we don't know why, really.
I see. Okay. And for ventilation, I think there's non-invasive ventilation as well. Am I right?
Yeah, so in the UK, most patients will be offered non-invasive ventilation. Tracheostomy ventilation is currently offered in the US and few European countries, but in the UK, I think we feel that the quality of life of the patient is so limited. And I mean, of course, there is also the question of resources that we always have to bear in mind, but at the moment in the UK, tracheostomy ventilation is not routinely offered. I've had a patient recently in clinic who has had some queries about it. I've referred her to the ventilation team to discuss it further, but at the moment we don't offer that in the UK.
Is there a difference in lifespan, whether you go for non-invasive, or if you go down the route of tracheostomy and ventilation, presumably you could live longer, or perhaps
You
not
can
that
live
much?
longer, but remember, you will still lose your speech. You'll probably become
Yeah.
non-communicative. You'll be fully debilitated. You know, you'll be bedbound by the end of it. So it's very difficult. And you will always start off with non-invasive ventilation first. So even if you want tracheostomy ventilation, you will be offered, you know, NIV first. And if then things become difficult because of swallowing problems or difficulties tolerating the mask, then you will go on to tracheostomy if it is available.
I see. All right. Okay. Thank you. Any other questions from others?
Thanks very much for the talk. I just had one question, if that was all right, regarding initial investigation for these patients with respect to nerve conduction studies versus EMG. Is there one that's favored over the other, or do both need to be done at the same time to give us the best possible chance of getting a diagnosis? Or
they are normally done together, and they should be done together. Yeah, because you don't expect any sensory changes in motor neuron disease. And also the pattern of denervation can be very useful. So if the denervation is following a root lesion, that can be quite useful. If there is denervation outside that particular, you know, territory, you may, you know, start questioning your clinical impression. But you need both usually.
thank you.
Does anyone else have any questions? Feel free to unmute your microphone if you do. Okay, well, I don't think there's any more questions.
Okay.
So thank you again.
Thank you very much.
Thank you very
Take care.
much.
Thank you.
No
Thanks.
problem. Take
Bye-bye.
care.
Bye.
Bye-bye.